We're talking with Dr. Stieg this morning about doing brain surgery while I'm still awake.
It's being done more frequently because we are now able to do functional MRI scans where we can determine the relationship between what we call eloquent cortex, important cortex, meaning that speech is localized there, or motor or visual function. And that gives us the warning that we probably should try to do something awake in order to monitor exactly where that function is localized.
Now, we're talking about a craniotomy versus an awake craniotomy. Is there a difference?
Yes. A routine craniotomy would mean that we're doing our brain surgery with the patient asleep. So the anesthesiologist puts a breathing tube in, and the patient is completely out, completely unaware of what is going on around them. Versus the awake craniotomy is the anesthesiologist puts them asleep but without a tube, and we also use a large amount of what's called local anesthesia, like lidocaine or Marcaine. And then with that, we are able to make the incisions and do the bony work, but once we get to the brain, which itself does not feel, we are then able to allow the patient to awaken, and we can map out specific functions that we're looking for.
What does the patient say afterward as far as how it feels?
It varies. Some patients, depending upon how long the operation goes. I mean, the normal operation for brain surgery is about 4 hours, and those patients actually like it better than the general anesthesia because they wake up with fewer side effects from the general anesthesia. As I said, the pain is usually very well controlled with the local drugs that we use, and also the anesthesiologist can make them feel a little bit happy. So they don't have those secondary side effects from the general anesthetic agents that they use.
Can you speak to the patient while the surgery is going on?
Absolutely. There are two things that two areas that we're typically most worried about with awake craniotomies. One is with the speech cortex, and the other one is the motor cortex. So if we're trying to map out the speech cortex, we have the patient has large drapes, but then a neuropsychologist is underneath with them, and we will have the patient count backwards, we'll have the patient read, we'll have the patient look at pictures and describe them to us, and then while we're actually taking the lesion out, the neuropsychologist will continue to have a spontaneous conversation with them, and we will intermittently stimulate the brain to make sure that where we plan on going won't hurt the patient.
Have you ever had a patient or heard about a patient freaking out, or are they too relaxed to freak out?
Patients can get a little bit anxious, and what we have to do, usually it's related to there's some scalp pain, or there's some pain. There's a covering of the brain called the dura, and sometimes that can start to hurt a little bit, and then what we have to do is give them another injection of local anesthetic, and we can usually get them to calm down.
How do patients and their families react to hearing about an awake craniotomy?
Like anything else, it's in the way that we present this to them. Obviously, some patients will have a great amount of emotional difficulty with it, but by and large, most patients, when they realize that we're doing this for them to be most safe, and I can reassure them that we use plenty of local anesthesia and they will be asleep during the parts that might be painful, they understand that this is being done to protect their brain function, so they rationally make the right decision.
Is this type of surgery more or less risky?
It's more, in one essence, it's more risky because we're doing the awake craniotomy or the awake brain surgery because we know that the pathology, the tumor, the vascular lesion, is very close to important brain. So that makes it more risky. On the flip side, it's less risky because we are being extremely meticulous where we can correlate what we're seeing with the preoperatively acquired functional MRI scan with what we're finding physiologically, with direct brain mapping. And we can really make sure that where we're going in the brain is safe. And at the end of the day, we always have to remember as surgeons we can back out, meaning that if it's just not safe to go through a part of the brain to achieve the goal, We have to follow our mantra, which is do no harm.
Are there cases where having a patient awake just can't be done?
Yes, I've had to do that on 2 occasions where we felt that through the functional MRI studies that we had a trajectory, and then when we got in there and stimulated the brain, we just couldn't find a pathway to get at it in a straightforward, easy, and safe manner. Went out and spoke with the family members. We all agreed that not being over-aggressive at that time was the appropriate decision, and we backed out.
Any uses down the road that you see for this kind of procedure?
What's really going to happen down the road is our functional MRI imaging is going to get much better. And it also, not only can we correlate the functional MRI scan, but there's something called diffusion tractography, where we can actually look at the brain cells going through the brain, projecting from one region to another. And these are areas that we also don't want to disrupt with surgical approaches. And that is currently and will get better in the future, affecting the way we select to get at some pathologies deep within a patient's brain. So this is all going to get much better. We're also going to be able to do it much less invasively, and by that I mean we're going to be, instead of doing craniotomies, we're going to be doing things through endoscopes, and hopefully we'll be doing things with little laser probes where we just go in and heat up the area of pathology.
Last question, is it true that the brain feels no pain?
Absolutely. That's the reason we can get away with this. Yeah. There aren't any C fibers or D fibers in the brain, so it doesn't perceive the pain like you do if we were operating on a limb.
Mm-hmm. Mm-hmm. So then, how do you explain headache? That's just the matter around the brain.
Well, a headache is not due to the brain itself. It's due to inflammation of the covering of the brain. Remember, earlier I referred to that dura mater. Mm. And then there are also, in the blood vessels of the brain, there are some receptors that can perceive pain as well.
Anything else you want to add about the procedure?
I think that gives the listener a good idea. Again, I would just want to emphasize that this is exceedingly safe, and it's very comfortable for the patient. Clearly, as surgeons and physicians, we wouldn't recommend this to somebody unless it was in their best medical interest.